alternative option is, if somebody is not very comfortable in peeling the ILM under PFCL is, then, one can raise the flap of ILM under fluid. And once we have a, good amount of flap, then we can put the PFCL to flatten the retina and complete the rhexis.
Okay, so first of all, thank you, Chirag, for allowing me to come into this course, and sorry for coming in late. I was at another session. Okay, so this is a case of a tractional detachment, actually, more like an end stage to a vasculitis. It was a young girl with having a lot of traction post maybe a vasculitis episode at some point. And what you see here is that after removing a bit of the hemorrhage which had dehemoglobinized, and there we kind of clean up the media and then try to explore the exact area of traction. What you see here is this whole temporal retina is under stress. If you can make out that whole area is under stress. And I just wanted to show you that I planned that I would do a retinectomy and release it, and just want you to see how it just keeps extending more and more. And this is something that we sometimes encounter, and I would like opinions of people here, especially Pramod, Chirag, to suggest what all they would do. And you see how it extends and how it retracts the posterior part of the flap towards the macula. And then slowly I kind of try to make radial nicks to relieve the traction. I also put a buckle because I realized that this case would be difficult to manage without a buckle. So we put a buckle externally and gave some external tamponade so as to relieve. And now you can see that it did help. You can certainly see that plane of retina is now well aligned over the buckle in such a situation, in spite of that whole posterior flap. And then I could flatten it enough to do a good laser. The laser, of course, is very posterior and very close to the fovea, but this is the best outcome that I could achieve at that case. But I don't think my intention was to have made such a big retinectomy which extended posteriorly. But during the surgery, I don't think I could essentially control it. So any ideas whatsoever that you think could have been done differently?
Definitely, particularly when you have shortening. Either one way is you to cut the retina extensively or support from outside with a buckle. Yeah. I think these are the eyes, I think probably I totally agree, would have been a better option. Because otherwise, he would have been at least 2 o'clock on either side going beyond that.
Much more than that.
Much more than what it is.
Yeah.
And then with larger the retinotomy, higher the risk of PVR subsequently or having particularly already compromised eyes here.
Yeah. Sure.
I agree totally, sir, that, putting buckle in planned retinotomy would reduce the size of retinotomy. Sure. And as you have mentioned that sometimes we may have to put a radial nick to prevent this, as you rightly said.
Right. Okay. Another situation is a case of actually a giant retinal tear, which while we with a lot of choroidals pre-existing in them. So this is the case, what you can see, and you see even when I'm trying to put the cutter inside, you can see that because of the choroidal, there is still a flap. Even though we put the cannulas at the right place, there is still some tissue which was coming in my way while going inside. But of course we could go in, and this is what you see inside. A very yellowish, typical part of these choroidal-based big arteries, they might give you a yellowish hue. So what I did is my first aim was to do a little bit of core to create space that I could then put some perfluorocarbon and then explore how to proceed. So when I start doing that, I realized that the cannula, which I had originally checked to be well in place, seemed to have been dragged back suprachoroidally. So you can see that I'm trying to relieve it from the tissue concerned and trying to free it from all that tissue. Just because of the choroidal, you sometimes don't have control over how. And then instantly, as soon as the cannula is coming in the vitreous, you see again a space created instantly, which was not there before. Suddenly, the view becomes much better. So I fill it up with the perfluorocarbon, flatten it well, and then you see this is the edge of the giant tear on this side. In fact, the tear was on the side. You still see these residual choroidals which are there but have well flattened now and have done a more posterior barrage. Because in these eyes, what happens is that the oil fill that you do very fast loses its tamponade because the choroidals will regress and then the oil fill is incomplete and and they were prone to inferior detachments very commonly, and many times it is that after 2 months you are going back to push some oil inside. Or other option is that you try and drain some of it. If it's extensive, I sometimes try to drain some of these choroidals. But in some situations where you already had problems with the cannulas and other things and you've stabilized the eye, I don't make this extra effort of again going and poking and trying to drain fluid. You don't want to end up with some hemorrhagic component coming in. And in these cases, we always also try to give a subtenon steroid of some sort, which would help relieve the choroidals and the overall inflammation of the surgery, everything much faster in these cases. So I would like your opinions on that.
I think we would have done the same, as you rightly said. Having unusual choroidals, the first thing what we would see is the placement of cannula.
Yeah.
And then if necessary, we change the place of cannula or reinsert it again, and then go ahead with the surgery. And with the choroidals, if we think that the surgical planning we can execute with the present choroidals, we'll go ahead with the surgery without disturbing it.
Basically, glue, first thing is because you see that yellowish glow. That indicates you have inflammation here. It's not only detachment, associated some amount, and these are the eyes are more prone to develop PVR, recurrent detachment. Okay. Now, choroidals, like invariably you have some amount of choroidal